Let's get started. Welcome, everyone. I wanted to welcome everyone to the webinar. Most of you know who I am by now. My name is Dr. Lauren Levine. I am your host. I'm your moderator. As usual, whenever we have this great speaker, we get a lot of people registered. We had around 600 people. What I've been saying for the last few years certainly rings true this evening, which is I hope that everyone's staying healthy and safe. Certainly if you're on the west coast of Florida, especially for you. But for all of us, I commend you for being here this evening, continuing your dental education. It's certainly been an up and down few years for a lot of practices, but the need for the education obviously never ends. And of course, you all know that because you're here. I'm only going to speak for a couple of minutes. I want to make sure that Dr. Nazarian can speak for as long as he needs. He had also mentioned to me that he wants to make sure that we leave some time for questions at the end. Most of you are familiar with the format. If you haven't been on these webinars in the past, our speaker will typically speak for 45 to 55 minutes or so, and then we're going to have some time for questions at the end. With 600 people registered, we obviously cannot do verbal questions. On your screen, you should have a GoToWebinar control panel. You just type in your question as you think about it. I will do my best to get to as many of the questions as we can. I never know how many questions we're going to get. Sometimes we get 5, sometimes we get 105. If we get a lot, I'll try to combine some together. I'll try to figure out what the themes are. We're going to be done within 90 minutes. So, in case we're getting close to that, I will cut it off because I want to be respectful of your time and our speaker's time as well. In the next few days, look for a couple of things. First off, the webinar is recorded. We are recording all of this. You'll get an email where you can download the recording. That usually takes a couple of days, so keep an eye on your inbox for that. It'll be a link. Sometimes it's a YouTube link, sometimes it's a direct link, but you will be able to review this at your leisure. During the webinar, Dr. Nazarian will be showing some systems that he uses, some products which are exclusive to Golden Dent. I want to thank them as always for sponsoring these webinars. I've known Kurt Lawler and Golden Dent for a long time. We've traveled together. We've done all these webinars for a bunch of years together. They're the ones that bring in these great speakers. They're the ones that help to develop the content. They're the ones that handle the CE. Kurt will come on right after Dr. Nazarian is done to make some special offers. And I would highly encourage you to stay around. The offers are usually only good for 24 to 48 hours. So you're going to want to stick around for that. Speaking of CE, I always get emails after the webinar asking me about CE. I'm going to try to bring it up at least a few times, and hopefully everyone will hear it. Basically, if you're here now and you're here at the end, you're going to get the CE. There's nothing you need to do. There's no registration or quiz or test or anything like that. I send them a list of everyone. We track when you logged in, when you logged out, and I get sent off to Golden Dent, and then they handle the CE. If you're only here for 6 minutes, you're not getting the CE, obviously. But if you're here for the bulk of the webinar, you will get those CE forms. So that can take a little bit longer than the recording. Usually that takes about a week or so. If you don't have it, say by next week, by all means, shoot me an email. I'll follow up with them just to make sure that they're going out. And with that out of the way, I am thrilled once again to welcome back Dr. Nazarian. He's been with us a number of times before. He has a private practice in Troy, Michigan, which is really emphasizing comprehensive and restorative care. He's a diplomat of the International Congress of Oral Implantologists, ICOI. If you read any journals, and you probably have seen his name because he writes a lot, his articles have been published in many of today's popular dental publications. He's consistently listed as a top dental educator. He's conducted just numerous lectures and hands-on workshops on aesthetic materials and implants, extractions, grafting, endodontics throughout the U.S. and really the entire world. He's the lead faculty for Amplified Dental Training, which teaches atraumatic extractions, grafting, immediate dentures, dental implants, endodontics. And obviously, he's an expert on lasers as well. So, Era, we're thrilled to have you back and looking forward to tonight's presentation.
Thank you so much, Dr. Levine. Good evening and welcome, everyone. This evening, our webinar will be talking about what laser dentistry can do for your practice. Our objectives for this evening are to give you a quick overview of some clinical case demonstration that's showing how we incorporate lasers into our practice, whether we're cutting soft tissue, uncovering implants, using them in endodontics. We'll definitely illustrate a lot of clinical photos of how a diode laser can perform these services, but most importantly, your patients can benefit from it as well as your practice. Most importantly, we're going to be illustrating from a practice management standpoint how we can make some of these procedures a lot more efficient as well as effective. So what can a laser do for your practice? There's about 20 plus dental applications. These range from dental soft tissue surgery to endodontic sterilization to periodontal sterilization, or as we call it, pocket decontamination, help solve peri-implantitis. We'll also show or illustrate sometimes how we'll take operculectomy or use these also for lesion removals. Lasers can also be used for teeth whitening. And depending on your state, you definitely want to check the laws, but your hygienist can incorporate soft tissue diode lasers in pocket decontamination when they're doing scaling and root planing. So there's obviously a lot of dental applications that we utilize lasers for. Some of the advantages of a dental laser include minimal bleeding. This can be during crown preparation, so we can put it on troughing so that we don't have to pack cord. We get clear margins when taking impressions, and we get the cauterization of the soft tissue. Obviously, there's minimal intraoperative pain for the patient. It's not as painful as taking a scalpel to someone. In some cases, minimal or no anesthetic is necessary depending on the procedure. The postoperative recovery is very quick, and there isn't scarring. So it's not going to leave scarring or gingival recession, which is very nice. Before incorporating lasers into my practice, I used to use electrosurge, and that shows you how long I've been practicing dentistry. And electrosurge would cut well, but the postoperative discomfort was very high. You'd get gingival recession, and obviously you did not want to use those around metal or around implants. So the laser has really done a lot for our practice. So laser energy, what are the different types of energy that we see from lasers? There's reflected, there's transmitted, there's scattered, and there's absorbed. And the absorbed is used to cut. So a diode laser energy is absorbed by two things, either hemoglobin, which is blood, or melanin, like skin. So if there's water that's present, we don't have to worry about that being absorbed by the laser if there's some moisture there. And most importantly, this is a soft tissue laser, so we're not doing osseous contouring with this. This is mainly used to cut tissue, for pain management, for whitening, or for decontamination. And most importantly, I utilize them a lot when uncovering implants, so we don't have to worry about touching the healing cap with a laser. It's not going to be affected. So here we see the graph of absorption of a laser radiation by tissue, and you can see mainly it's the melanin and the hemoglobin. Water and lipid are very, very low. So this evening, we'll show you how we incorporate Golden Dent's Woodpecker LX16 model. The nice thing about this model is you can move it from operatory to operatory very easily. It's very affordable. It's also very reliable and user-friendly. You'll see it's got some settings that already have almost every indication that you can use it for. So you don't have to set any frequency or time or anything. If you want to, you can do that yourself, but mainly everything has been preset. And clinically, we see this is a very proven technique, and we'll illustrate that in a moment. So the touch screen is very intelligent. It's interactive. It's a large touch screen, so you can see it, There's some lasers out on the market that are very small, so you can't really see the settings. You have to refer to like an index card or a different number for the procedure. This illustrates it with a little picture, which is very nice. And there's a little button located on the handpiece, so you just press that and it works very well. The metal hood, if you look, is very strong and sturdy. In fact, this is the handle here that you can carry it from operatory to operatory. There's mainly two types of wavelengths utilized by the LX16. One is stronger than the other. The 976 is the traditional infrared dental laser, the red laser. Due to its deep penetration in tissue, it's widely used for reduction of bacteria and periodontal disease and endodontic disease. And most importantly, this is the setting that we're utilizing for cutting. The 650 mode is used more for lower level laser output. It's actually known for photobiomodulation, which essentially is for wound healing and stimulation. So it's usually used for pain therapy. The nice thing is, depending on what tips you're using, some of them are disposable and some of them are reusable. They're color coded. There's a tool to use for bending the metal tip portion of the laser, obviously not the filament portion. We are using articulating paper to activate the tips, mainly just for cutting. So if we're using the laser tips for endo or for periodontal decontamination, obviously we don't need to activate that with articulating paper. We're just activating the gray tips, as we call them, and this is mainly for cutting. And if for some reason you start to get charring, there is a pen. It's a cutting device that's used to cut that portion of charring so that the laser is very efficient and effective. If we take a look at the multiple tips that are included, the MF3 are all the different types of cutting tips. They're the gray tips. We have the DT tips, which are mainly used for pain therapy. And then the BT8 is mainly used for tooth sensitivity. It almost looks like a curing light tip. There's also a whitening tip also included in the package, as well as the yellow and blue tips. The yellow tips are mainly used for endo, and the blue tips are used for perio decontamination. So when getting started, you can put in a password so that nobody else is using this. The battery power lasts very long, which is good. Golden Dent has a team that can do Zoom training if you purchase these lasers. So there's great support. And if you were ever to have an issue with a laser, they do have service and repairs that are done right there in Detroit. So it's not like buying this from a third party that you will never get support or service for. So Golden Dent backs everything up, which is very nice. Here are some of the preset functions. The surgery menu is divided into several different options. Mainly there's a surgery menu, there's a decontamination and pain therapy menu, and then there's also a whitening type of menu. So it tells you what tip to use for whatever preset functions that you're going to be doing. If you want to customize these programs, you can do that very easily. I found that these preset buttons work very well. So there's really no need to modify it. However, if you did want to increase the frequency or the time duration or anything, you can modify these and customize them to your liking. So again, the preset procedure modes, there's mainly three different windows or categories. One is surgery, which includes anything from frenectomy to gingivectomy to operculectomy, anything where you're sort of cutting the gum. It's the higher setting of the laser. Then we have what we call perio implant uncovery or peri-implantitis treatment and endo. This is a little bit of a lower setting. so that it's not affecting anything else, and it's preset so the power is not as intense. And then obviously we have soft tissue laser therapy. And so here we can see the different tips we can use for either pain therapy, aphthous ulcer, desensitization. If you have any herpetic outbreaks, using this setting can definitely shorten the duration of the herpetic outbreak. And most importantly, we get hemostasis if you just want to sort of cauterize the tissue and stop the bleeding. You get safety glasses with these, which is very nice. So not only the operator gets safety glasses, but the patient as well as the assistant in the room. So everything is all included, which is nice. So getting started, you want to make sure that the transmission and the tip are working by looking for the red circle before starting the procedure. In fact, when you're ready to start, a warning will come on that everybody should be wearing their safety glasses. You'll press a button to confirm that everybody is wearing the safety glasses. The laser will beep when it is in use, and while counting down the preset timer for the procedure. So if you're doing a procedure, if the counter time goes off, then the laser will stop and then you can move to a different area or a different tooth. Let's say if you're troughing for crown and bridge or something like that. So there's a very easy on and off button on the handpiece. So let's take a look at some clinical applications and see how the laser was utilized in my practice. So the patient presented to my practice looking to enhance her smile. And by looking at the golden proportion, we can clearly identify that the right central incisor, or tooth number 8, did have some bonding for discoloration and endodontically treated, I believe it was. But the gingival gum tissue that was around that was excessive. So we knew we need to remove that excess tissue. Now remember, this is a soft tissue laser, so we want to keep in mind the biologic width. And we know when we look at biologic width, the free gingival margin should be 3 millimeters away from the crest of the bone. So if the crest of the bone is not 3 millimeters away, then at this point, this tooth would need crown lengthening. But upon probing, we clearly identified that this was just excessive gum tissue, that this tooth did not need crown lengthening, but in fact, just a gingivectomy. So we first ordered a diagnostic wax up from the dental laboratory to illustrate how these teeth would look once we achieve cosmetic dentistry with porcelain veneers, but also showing where we would be doing the gingivectomy so that we would have some symmetry as indicated in the picture. So we know that the centrals should be at the same length. The laterals are usually a little bit more gummy, and the canines are usually, the free gingival margin is either right around where the centrals are or just slightly higher. So looking at this, we said we really don't need to disturb any of the other areas of where the gingival tissue is, but just tooth number 8. So utilizing the LX16 from Golden Dent, we put the setting to gingivectomy, and we identified where we need to contour this so that we would have symmetry of both central incisors. Here you can see the LX16 handle. You can see the little push button to activate, and you can see very quickly we're able to remove that gingival tissue. You can see there's no bleeding at all. And then usually once I achieve this type of gingivectomy, I'll take a cotton pellet with just that's just a little wet and just slough off this tissue that's been eliminated from the laser. So removing excess gingival tissue is very easily done with a diode laser, obviously. The common gingival aesthetic problems such as excessive gingival display as seen here, or anything that looks asymmetric to the eye. We know if we have symmetry, then things look nice. And you can see the peak power, frequency, time. These are all in the automatic preset setting. Here I'm just confirming this with the suck down of the wax up. So we know we're going to be lengthening these teeth. As you can see, notice there's a hole on the facial and the incisal of this clear template, and that's so that when we do the prepping, we know we have adequate reduction for the porcelain veneers. So obviously in the length, we don't really need to prep that much. We just have to shape it a little, and then on the facial, we're going to reduce a little bit. This is what it looks like after we've done the preparation for the porcelain veneers. Notice we've only prepped the facial aspect of these, and we've broken the contact. Here we have a nice impression. Notice it's just been prepped on the front. So these are very minimal prep veneers for this patient. What we like to have is a slight mesial inclination. I think that looks more natural than teeth being straight up and down. So you can see the slight mesial inclination that we're looking for, especially when we're just doing 4 veneers and the patient has the rest of their natural teeth. If we do a full mouth reconstruction, we still will try to have a mesial tip, but we would probably go much lighter in color. So these are more natural looking veneers since we only did 4. Notice the gingival tissue has healed very nicely. And so this patient was very satisfied with the aesthetic result. Well, let's take a look at a lower infected molar using laser assisted therapy. There are several papers out there talking about lasers being used during root canal therapy to sort of sterilize the canal. So that's in the literature, which is very nice. But a patient presented to my practice with severe discomfort, and especially to hot and cold, and it was lingering for a very long time. So radiographically, we identify that tooth number 31 had a large carious lesion on the distal portion under the amalgam restoration, and it was in very close proximity to the pulp chamber. In addition to that, we can also see that there was a periapical radiolucency on this tooth. So this was definitely a hot tooth, as indicated by this radiograph. Utilizing the DemoDent patient education model, we illustrated to the patient the nerve area illustrated in the pink, and where the decay was probably underneath the filling, there may have been a crack, and this led to the abscess. So utilizing that, the patient agreed, after we utilized that to educate the patient agreed to have the root canal done to alleviate the pain, followed with a core and crown restoration. So the first thing I'll do after I've anesthetized the patient and taken a radiograph, we're going to estimate the length of the roots, and we can see very quickly that these are somewhat longer roots. Usually we see tooth number 31 more in about the 21 millimeter length. So the first thing is to create an access opening. We know with a mandibular second molar, usually the tendency is to make a trapezoidal access opening, and usually you find 2 canals in the anterior portion and 1 to 2 canals in the distal portion. And so we're going to access this, remove the decay, and create a straight line access. I don't have a ton of burrs that I use. Usually it's just these 2 work very well in opening the access, and then the safe sider works well in opening it up so that we have a straight line access. The next step we'll do is create a glide path. So we'll use either a 10 or a 15. In this particular case, they didn't look really calcified, so I could go straight to a 15 if necessary. What is a glide path? Essentially, it's just a smooth radicular tunnel from the canal orifice to the physiological terminus, or the constriction as we know it. Its minimal size should be loose. The glide path must be discovered if already present in the endodontic anatomy, or prepared if it's not. So if it's calcified, we'll use the 10 and sort of chip away using a little bit of EDTA to make sure we get to length before we put any type of rotary file in. A common mistake I've seen is that dentists will jump right to the rotary files before they even get a glide path, and that's when you usually see separation of an endodontic file. Irrigation is very essential. These are also available from Golden Dent. Usually I'm starting with sodium hypochlorite. If we find that there is a calcification in there or the file's not getting into the full length, we'll use a little bit of EDTA. They also have a combination of EDTA and chlorhexidine for severely infected tooth. My go-to though is the 5% sodium hypochlorite, which is already pre-mixed for you. So identifying the various apex lengths is important. A lot of times people will look at the radiographic apex. If you're doing that, you want to reduce about 1 millimeter because really when you look at where the anatomical apex is, it's shorter than the radiographic apex. Ideally, we're looking at the apical constriction, and this can most easily be found using an apex indicator. So my go-to usually is not using a radiograph to determine the length with a file. However, you can do that, but it is rather using an apex indicator. And so here you can see the file has been placed and we're at 0, 0, meaning we're not overextended and we're not shy of the constriction, but literally right at the constriction. And so this is also available from Golden Dent. Here we have the wireless endo handpiece, and we have the preset Golden Dent taper files that will go right into the system. Usually we're using about 300 to 350 RPM with 3D Newton centimeters torque. And so I have yet to see separation because these have a various taper, which is nice. So usually you're starting with the SX file, and then you're going to the shapers and then the finishers. And because these have various tapers, you don't see these binding in the canal, which works very well. When we're going step by step, we obviously want to make sure that we rinse, recapitulate with a 10 or 15, and then rinse again before we move on to the next rotary file. Recapitulation is literally re-instrumentation with a smaller instrument following each irrigation step, and it's used to remove the excess debris so we don't have clogging at the tip or apex. Once we've gone through our set of rotary files, we'll go ahead and dry with customized paper points. At this point, I started implementing the LX16 to disinfect the canals. So once the irrigants and rinses have been used, this will kill some of the bacteria into the dental tubules. However, the laser light penetrates even deeper into the dentin and kills 1,000 times or more microns. So you literally are sterilizing this tooth for the most part, more so than any of the other irrigants, even combined. So I found what, especially when I'm using, when I'm doing root canal therapy, I'm using this laser therapy to further sterilize and decontaminate the canals. So the Woodpecker diode laser, when used for root canal therapy, we're going to be using the yellow tip. They're longer tips, which are very nice. It's a 1.5 watt continuous mode, and you're in there and just going in and out and in a circular motion for about 45 seconds to a minute, especially when they're that infected. And you're going to do this before obturation. Again, this is what the endo tips look like in the box. They're yellow, so yellow indicates endo, the blue are perio. So these two types of tips are not cutting. The cutting ones are the gray on the bottom right. And then obviously we have the BT8, which is for desensitizing teeth, and then all the other pain therapy tips. And then, excuse me, the whitening tip. So here we're going to use our customized gutta percha. When doing any type of obturation, we want to confirm that the gutta percha is not at the radiographic apex, but somewhere between the constriction and the anatomical apex. So sometimes people will extend it past the anatomical apex because it looks better on a radiograph. It looks like it's complete, but it may in fact be overextended. So utilizing an apex indicator is a must in my practice. So here we have a nice sketch that illustrates the apical constriction, the anatomical apex, and somewhere between there is what we call the green zone, is where your gutta percha should finish, ideally, not the radiographic apex. This is one of the sealers that are available. This is also available through Golden Dent. The nice thing with this is it's just paste A and B. You mix them on the pad. It's got great adhesion to the gutta percha as well as dentin. It seals very well. It flows very well. It's not soluble because there is a resin component to that, which is nice. But if it were to go out of the apex, it is biocompatible. And most importantly, I like to see it white on an x-ray, so it's got great radio opacity. When placing a sealer into these canals, I like to use a lentilo. And here you can see our endo is nice and complete. We did the core buildup. The core buildup is with the Wago core, which is zirconium infused for strength. And when treating these patients, especially infected teeth, I do like to give them 4 milligrams of dexamethasone. This helps prevent any type of discomfort on biting to the patient. So we just give this to them, mark it in the chart that we gave them this 4 milligrams, and this helps tremendously when people have discomfort afterwards because you instrumented the teeth. So this helps prevent that, which is really good. And then obviously we'll go over any type of post-operative instructions and let the patient know they definitely need to come back for cuspal coverage with a full crown. So here you can see our preparation. We also let them know that, hey, we could take a scan for them to identify if there's enough bone for an implant. And so the patient decided they definitely want to do that later as well. Here we have the Panasil impression tray, heavy in light body from Kettenbach. We take the impression, and then within 8 to 9 working days, we get the crown back from the laboratory, the full zirconia, and cement that. So here you've seen where we've used the LX16 not only for gingival contouring, but for endodontic therapy. Well, what about for removing excessive tissue over a wisdom tooth or a second molar if it's an adolescent or a teenager? So we do use the laser therapy for operculectomies. Here we can see where we lasered that excessive tissue over the second molar. And the bleeding, very little bleeding, if any. So that's cauterized very quickly. And then we went ahead and did sealants for that patient. Here's another example of someone with operculectomies that were achieved with the laser. And then we went ahead and we opened those up and we actually put a glass ionomer restoration in there until this gum tissue settles. And then later, if that patient needs composite restorations, we can go ahead and do so. But this was a resin modified glass ionomer we used in this patient. How about an aesthetic makeover? Again, the first thing we're going to look at is symmetry. Do we have symmetry? Obviously, this is a patient who grinds their teeth, as indicated here. So looking at the gingival architecture here, we're going to go ahead and indicate where we need to do the laser therapy on tooth number 9. We accomplished that and prep the teeth Since these were severely worn, we did recommend crown restorations instead of veneers. And we had only done the wax up for the upper teeth, and the patient was so pleased with the temporary on the top that she said, you know what, why don't you go ahead and prep the lower teeth as well. So although we didn't have a wax up, we just utilized a pre-op impression, and then we instructed the lab what we wanted for size, shape, and contour. So here's her final restorations. So we literally went first molar to first molar. So there's her before and after. And this was, the contouring was accomplished with a laser, as you can see. So healing was very nice. How about an anterior retreat? Patient presented complaining of discomfort under her nose. Upon radiographic examination, we saw that tooth 9 had a large periapical lesion. This tooth supposedly was root canaled about 17 years ago, and she had some veneers that were placed on her anterior 6 teeth. So our first treatment was to go ahead and treat this abscess. So we measured the tooth, anesthetized the patient, and determined our working length. And we went ahead and accessed the composite core that was already existing in the tooth. And using a Gates Glidden, we went ahead and removed the gutta percha. We want to ensure that we got apical patency, which essentially refers to the passage of the file beyond the confines of the root in an effort to prevent blockage of the foramen. But also we wanted to go through because we wanted to access that radiolucency. So in this case, we went ahead and treated the teeth, but we went up to the F4 followed by the F5 size golden dent files. So you can see that here. These are very inexpensive files, so we're only using these once and discarding them. So I'm never going to worry about separation, not only because of the variable taper, but also because we're only using these once because of the low cost. Here you can see where we're measuring, and we just work up to our files. Again, it's imperative that you rinse and recapitulate between each step. We're going to go ahead and rinse with the sodium hypochlorite and EDTA. And then following the removal of the debris and smear layer using the EDTA, not only do we use sodium hypochlorite to finally rinse, but then disinfected the canal with the laser. And so again, we're going to use this laser tip. We're going to go ahead and fill the gutta percha, and you can see the nice puff of sealer. 2 weeks post-operatively, we went ahead and put the core in. So I didn't do it immediately because I wanted to see how this tooth responded. And upon closer examination, you can see where our core is from the occlusal aspect or occlusal view. And you can see where these teeth were worn, eroded. So we recommended, if the patient wanted to, we could enhance her smile by doing a full mouth reconstruction. So we recommend a diagnostic wax up. Patient accepted, so we went ahead and started prepping the teeth. This is the digital copy of the wax up that the lab would use for the final creation of the restoration. So here we see our reduction template. Here we're recommending to fabricate a temporary before the impression. Why do I recommend that? Well, you can clearly see that the lingual portion of 12 and 13 have not been reduced enough, as well as the lingual portion of the anterior teeth. So by making a temp at the beginning, after preparation, before you take the impression, you can identify the areas where you need to redefine the preparation or prep deeper. And so here you can clearly see that the lingual aspect needs to be prepped a little bit more on the anterior 6 especially, and on a couple of the premolars. In the past, we would take the impression, make a temp, and then say, oh, now I have to take a new impression because I haven't prepped enough, or the lab would have to make this a little bulkier, and then now it created problems with occlusion. So a pearl for you to take from this evening's webinar, in addition to the laser information, is to fabricate a temp. Now you may have to make a new temp, which is okay, but I'm almost using this to confirm I have enough reduction. So this is the B1 shade we used from Kettenbach. This is the Visle temp, and here on the bottom you can see I definitely needed to prepare these teeth a little deeper. Once we've prepared them, we'll go ahead and use this jig to take a bite, fabricate the provisionals, and send the patient home with the provisionals, and indicate to the laboratory we want to get an exocad preview of the restorations before milling. We approve the design, so they go ahead and fabricate these in aesthetic zirconia. And this was just in the B1 shade. We use a resin modified glass ionomer. This is from SDI. And so this is very biocompatible. It bonds very well to zirconia without having to surface treat the zirconia. And it cleans up well. As you can see, the gingival tissue is not really irritated. And as we look at the before and after, this all stemmed from us treating number 9, utilizing the Golden Dent endo system. In addition, we also use the laser LX16. So it does open up a lot of different avenues for your practice. Let me show you just another couple cases. This was a full mouth reconstruction. We offered several options of treatment with implant therapy, and very quickly we determined these teeth all need to come out. The patient decided that she wanted to go with overdenture or snap-in teeth treatment because that fit her budget compared to fixed implants. So upon radiographic examination, we illustrated the most key positions to place the implants, as illustrated in this photo. And if the patient wanted to upgrade in the future to fixed, we can easily do that on the bottom. In the top, if we decided to do it, then we would have to place 2 more implants on an angle in the posterior. So here you can see how we plan it out. On the day of treatment, we anesthetize the patient. Utilizing the wedge, we'll loosen the teeth. In this case, a lot of the crowns just popped off. So we went straight to the physics forceps to further extract these teeth. We reflected a flap. Utilizing a surgical guide, we place the add-in Touareg implants, also available from Golden Dent. They are a distributor now. Using add-in's guided system, we place the 4 implants, placed healing caps over there, and then placed the graft material. This is the particulate from Golden Dent called Goldenos. And then we'll go ahead and suture over this with primary closure. This way we can deliver an immediate denture on the top. I'll never load the implants in the upper arch because the bone is more D3, D4, but in the lower arch, I feel very comfortable loading add-ins Touareg implants. So we're gonna first remove the teeth. This is using the wedge to loosen the teeth. It's a great pre-step before you use the physics forceps. In some cases, you may have to section teeth. Here you could see some type of amalgam tattoo that I also removed. We're going to reflect a flap, place the surgical guide, go through our drilling sequence in add-ins guided kit, and then place their implants. In the premolar area, because there wasn't very much bone apical of where the roots were, that's where the mental foramens are, I didn't load those implants, I buried them. But with the 4 implants that we had great fixation, I felt comfortable placing the locators on there and loading those immediately. So here we're just trying in the lower denture to make sure there's a passive fit. Utilizing rubber dam and seafold towel, I'm going to block out the sutures and the surgical site so that when I do a hard pickup, I'm not getting acrylic into the surgical site. And so here you can see before cleanup what it looks like. This is the Tokiyama hard denture reline material. This is after trimming. And then we're going to do a soft reline in the upper arch. That's just blocking out the sutures with a seafold towel. And this is the mucoprin from Kettenbach. So on the day of surgery, the patient walks out with an upper relined immediate denture opposing an overdenture. This is what the immediate Panorex look like. Notice we didn't load 2 of those 6 implants on the bottom. And obviously the top implants we weren't going to load either because of poor quality bone. This is what it looked like about 6 to 8 weeks later. And then after 4 months, we said it's time for uncovery. So we wanted to identify where we needed to uncover. The spotter is like a metal detector. And so it indicates exactly where you need to uncover to find the implant. So this starts to beep when you're over the implant site. You'll take an Explorer. Obviously the patient would be anesthetized, poke it through the gum, and then utilizing the laser on the implant uncovery mode, we're going to go ahead and uncover that implant. So no longer do we have to go and start searching for this. Using the spotter, we can easily identify it and use the laser to remove that tissue quick and easy. And we don't have to worry about it zapping the laser or sparking or anything like that. So we placed the 2 other locators, relieved her existing overdenture, that's a temporary overdenture, and picked those 2 housings up, and then took an impression for the final restorations, which would be metal reinforced. And so this is what it looked like. Here we have the metal try-in with the metal reinforcement. We're going to take a bite registration utilizing the futar from Kettenbach. Here we have the wax try-in and then the final delivery of the overdentures. Again, we were able to uncover these utilizing the LX16. Lastly, we have another aesthetic case. Again, we're looking for symmetry and we don't see that. The patient was dissatisfied with her smile, so she came to me for aesthetic makeover, utilizing porcelain veneers in the anterior and crowns in the posterior. So we first started with a diagnostic wax up, identified the area that we need to laser, set the laser at gingivectomy. Again, we're going to be using the gray tips for cutting. And so here you can see the laser in use. No bleeding. So this is what it looks like. We have some symmetry. And so now we'll go ahead and do our reduction grooves for the porcelain veneers. We'll go ahead and take an impression as well as a bite. This is just illustrating the bite with the Kettenbach futar. And here we have the temporary immediately after preparation once we've done the impression and bite. So there's a variety of different things that we could utilize the laser for in addition to what I've shown you. This is just a handful that I've documented. But definitely give Golden Dent a call to see if this laser works for your practice. I guarantee you it'll pay for itself very quickly. Your hygienists will love utilizing that for pocket decontamination. It helps with bacterial reduction, as we've already indicated. So, Dr. Levine, I'll give it back to you.
Thank you. And we're going to turn things over to Kurt Lawler. As I mentioned at the beginning of the webinar, Kurt's got some specials that he's going to be presenting. I also wanted to remind people, especially for those of you who may have showed up a few minutes late, that the webinar was recorded, and that recording should go out in the next couple of days. And for continuing education credits, Golden Dent will be handling that. It takes about a week or so. If you've been here for the bulk of the webinar, then you're going to get to see. There's nothing you need to do. There's no quiz or registration or anything like that. I send them the list. It shows when you logged in, when you logged out, and then they will send out the CE. So, Kurt, I'm going to turn it over to you.
All right, Lauren, thank you. I appreciate it. We get a lot of dentists that join these webinars on a regular basis. So if you're back with us this evening, I appreciate it. If you're new, we're a Detroit-based dental company that focuses on providing simple, predictable, and unconventional dental products that are different and clinically effective, starting with the physics forceps was our first product. So on the webinar this evening, we showed a few applications for the Woodpecker LX16 laser. If anybody is interested in the laser and for investing your time with us this evening, we are offering a 20% off coupon code. Not only does that work on the LX16 laser, it actually does work site-wide, with the asterisk on that being it does not work on other promotional offers. So if you see a 5+1, we always get doctors that ask us about this. If there's 5+1 deals on the website, the code is not going to work on those on top of that discount. We look at it as sort of a double promotional item, and that will not work. So the code is RED. So it's just RED, which will give you 20% off at golden-dent.com. That's going to be on the LX16 laser and then any of our other dental products, which I'll touch on here quickly. And if you're already familiar with our products, such as Osteogen plugs or Goldos bone graft or endo products, it's a good opportunity to stock up on some of those products and save with the 20% off discount code. The deal is for 24 hours, as we've already mentioned on the webinar, so it's good through tomorrow, the 28th. And as I mentioned, 20% off on the LX16 model will bring it down to $47.97. So it saves $1,200, which is a great price on this model of this motor. We added the Woodpecker brand a little over a year ago. We've been very happy with the products clinically. The feedback's been great from our customers over the last year or so, whether it's with the curing light or the electric motor, or the other Woodpecker products that we've had. The LX16 laser model is one of the newest products that we've added now that it finally has FDA approval here in the States. So at Golden Dent, I guess we did show a case this evening. We have a full endo line. So we have the Woodpecker endo motors, which the feedback's been great. We've had those for quite some time. That's actually what we started with, was the AI endo motor. We also have their endo obturation system, apex locator, and we have the equivalent of a Pro Taper Gold or a Wave 1 Gold type endo file. If you're using those and are looking to save a little bit of money on those types of files, consider the Golden Dent brand, which you can see on our website. This is kind of what started it all for us. We've been doing extraction classes with Dr. Nazarian for many, many years. I guess back to 2007, I think, is when we started the live patient extraction classes, which I'll mention here in a moment. But we have the physics forceps. We have all other kinds of different extraction and grafting instruments. If you're looking for a new simple graft kit, or maybe even a new conventional 150 or 151, we do have those available, as well as our PGA brand of sutures and our bone graft and osteogen plugs, and really anything related to extractions and grafting. It's a good opportunity to use that code on. For restorative, so that's the Woodpecker curing light called the O-Star. Great light. It's like around $500 before the discount code. That's a really good seller for us. It's a wide spectrum 10mm lens curing light. I got an email today for another curing light that was, over $2,000. I think this one's clinically equivalent to that light, and it's around $500. So it's something definitely to take a look at. We also have our sectional matrix system and our Wago Fill and our Wago Core, which is a composite material in our restorative brands. So let me just mention our classes real quick before I turn it back over to the Q&A section. We have Amplify Dental Training. That's our education program as part of Golden Dent. And you'll see some photos here of our past classes. So we do live patient extraction classes. We do live patient grafting programs. We do full arch reconstruction guided implant classes. And then we have our endo for the GP class, which is another one that we offer here in Detroit. So this is coming up here pretty quick. I just wanted to mention it. So October 7th, that's our next endo for the GP class, which is a one-day hands-on model class here in our office in Detroit with Dr. Nazarian. Then followed up the next weekend, we have EM2. This is a live patient program. So we'll see 50, 60, 70 patients, depending on how the day goes. And all the participants do the extractions, and then they do all the grafting procedures. So day one is a very comprehensive lecture with Dr. Nazarian going over extractions, grafting, suturing, everything related to prepping the socket site for dental implants. And then day two, you get to do everything on live patients. So there's no licensing restrictions or traveling out of the country or anything really special like that that's needed. We provide everything for you here in Detroit, and as long as you're licensed dentist in the US, you're able to attend at our teaching facility. After that, we've got coming up some of our implant classes again. So November 4th and 5th is our dental implants for the GP. This is a nice hands-on classroom-based program. We'll do one single guided implant on a model, and then also one single freehand implant on a model. And again, this is with Dr. Nazarian here in our office in Detroit. So it's coming up November 4th and 5th. And then November 18th and 19th, we got a lot of classes coming up here in the next couple months. This is our live patient extraction class. This is the very first class we ever did. We started with AMP1, and this is a live patient extraction class. Again, we'll see 65, 75, sometimes over 100 patients, just depending on how the patient flow is going and how quickly the attendees are getting through the patients. But this one, you extract the teeth on the patients that are provided. So again, there's no inconvenience really of special licensing, traveling out of the country, getting here. You just have to show up. We have the patients provided for you. And after day one of going through a comprehensive lecture with Dr. Nazarian, we do all the extraction procedures on the live patients. And so that's another class to consider, which is coming up November 18th and 19th. With that, I will leave the code on the screen here, which is 20% off, which is red is the code. And if you're interested in a laser, or if you're not quite ready for the laser, take advantage of the coupon code to order some of the products that you're already ordering from Golden Dent. Thank you for your time this evening, and I'll turn it back to Dr. Levine to go over the Q&A with Dr. Nazarian.
Thanks, Kurt. I think the first question is for you. So I'll keep you on for a second. I was asking about, I guess, the training for Canadian dentists. Are they still able to come down to Detroit and do the course?
Yes. So yes, it's open to any licensed U.S. or Canadian dentists at this time for the live patient component.
Perfect. Great. Okay. Thank you. Are you ready for some questions?
Absolutely.
Okay, I think some of this you had answered during the presentation. Some of these questions came up a little bit before, but it never hurts to just review some of it. Is it okay to use a diode laser to trim tissue back from a healing cap that gingiva has overgrown?
Yes, so using a soft tissue diode laser, it is safe to use that around metal of implants. An electrosurge is a big no-no, but a soft tissue diode laser, that's what it is intended for.
Okay.
So you're not going to see a big spark
Go
or
ahead.
anything like that, like we used to see with an electrosurge.
Oh yeah, that was always the highlight of my day.
Yeah.
Any chance you happen to know what the operating wavelength of the laser is?
I don't know that technical information. I'm sure Golden Dent can provide that for everyone. You know, more of a clinician, so I'm doing a lot of the clinical things with the preset. So I'm sure Kurt has that information for everyone.
Yeah, if he pops on, and if he doesn't have it, John, I'll forward the question. Oh, there, he's back on. Kurt, do you know?
Yeah, I do. I'd have to get out of the screen that I'm on here. I don't want to, I guess, mess that up what I have here on the screen. So, if anyone has questions like that, I mean, just if you click the link, we're actually going to send this evening with the recording of the webinar around like 10 o'clock Eastern time. If you click that, it has all the information. It takes you right to the page on the website. I just don't want to get out of the screen right now and mess this up.
Yeah, the two wavelengths that we talked about earlier was about 976, I think it was, and 650. So those are usually the two peak power wavelengths with like, it goes up to about 16 watts, I believe, if that's what they're asking.
Okay. What for someone that uses loops? Is there some type of safety glass that can be used to go over the loops that will allow them to continue using the loops of choice?
So depending on where your loops are, if they're external, like in other words, they just extend off your frame, then you could put something over it. However, you would have to really talk to your loops manufacturer. That's a good question. I don't use loops, so I just put them over my existing glasses. So the safety glasses are big enough that you can put them over your glasses. Whether it goes over glasses and loops, that's a great question. I don't know because I don't have loops. I don't use them.
Okay. Are you using hater bars on the maxillary arch to help support the upper implant retained denture? If not, why not?
So if you're using a hater bar, you need a certain amount of crown to height space. So hater bars I'm using if somebody's been edentulous for many, many years and the crown to height space is great. Otherwise, if you use a hater bar and you haven't reduced enough of the bone, your overdenture gets very thin and you start to see it crack. So I'm only using a hater bar in those cases where they've been edentulous for a long time and there's enough crown to height space for a bar. Now, the other thing to keep in mind, locators, if used in the maxillary arch, if I'm doing them independent of a hater bar, then I'm staying within the pre-maxilla because the bone in the posterior maxilla is not ideal for self-standing implants. If you're fixating them for a hater bar or if you're fixating them for fixed, then I would go ahead and put them more towards the posterior. But if you're doing a hater bar with attachment overdenture, your cost just went up to very close to what it would cost you for a fixed hybrid restoration. So at that point, I would just offer a hybrid restoration. But no, in this particular case, the crown to height space, if you saw the denture was thin, so we go with the self-standing implants in the pre-maxilla.
Okay. What about, can you use the laser for crown lengthening? I mean, obviously it's not going to be if you need to resect bone, but for like soft tissue crown lengthening, will it work for that?
Yeah, so then at that point we would just call it a gingivectomy if you're just doing the gum. But if they're asking about like, can you do the contouring with a laser first and then reflect the flap, you could do that, but you have to do osseous contouring. So there always has to be 3 millimeters of distance or 3 millimeters biologic width, as we call it, from the free gingival margin to the bone. So if you reduce the free gingival margin so that's only 1 millimeter above the bone, even if you use the laser or whatever, that gum will be very red and puffy and it will be an area of inflammation. The body always wants 3 millimeters of distance from the free gingival margin to bone.
Yep. Wow, I think we're out of questions here already. We're early, so I'll turn it back to you, Ara, to close it up, and then we'll call it a night.
Okay, well, thank you, Dr. Levine, for giving us this platform to be able to share this information with everyone. Gosh, I think we've been working together, what, almost 12 years now?
Something like that. Yeah, it's been quite some time.
Yeah. So I always appreciate and always look forward to your webinars when there's even other speakers. So thank you again for what you do. Kurt, thank you from Golden Dent, and everybody have a great evening.
Thank you. Well, you know, the feelings are mutual. We are thrilled to be able to share from your expertise. I think this is part of the reason that Golden Dent is always asking if you're available, because we always get a great turnout. You know, I've had the pleasure of watching your presentations for a number of years, and anyone that's been on the previous webinars know you're not getting the same stuff regurgitated time and time again. These are all new cases, new information. It's always, I think, just really informative. As a final reminder, the webinar is recorded, so the recording will go out on the next, probably later tonight, tomorrow. Usually they do it within 24 hours. The CE forms take a little bit longer. It can take about a week or so. If you have made it this far and you didn't just log on 5 minutes ago, then you're going to get a CE certificate that's done automatically. I send the list to Golden Dent. They will go through it. They'll make sure that you're on for the bulk of the webinar, and then they send out the CE forms. But that does take the better part of a week or so. We thank Golden Dent for bringing in Dr. Nazarian, for continuing to sponsor these webinars. We thank Dr. Nazarian, obviously, for his expertise. And thanks to all of you. I know your time is valuable, and we do these webinars on a regular basis. All of you who are here this evening are part of my invitation list. You'll be invited to future webinars as well. So please stay safe and healthy out there, and we look forward to seeing you all on the next webinar. Good night, everyone.